not for myself personally. Hey, it's been a hot minute since I've done an Ask Me Anything. No, not for myself personally. This was not embarrassing to talk about. But I am careful that I don't want to embarrass family. Even though it's my issue, I understand that it's a sensitive topic to be discussed outwardly for other people, and so not all of my family know that this platform even exists. If they find it, great. It's not like I'm like, hey, I'm talking about on Instagram to the whole world. Not sure they'd be super supportive of it. Not that that matters, but just I'm not going to go around telling the people who I think would be embarrassed by me telling the story. But personally, no, it's not embarrassing for me. Yes, my grade has changed. So when I was originally diagnosed 5 weeks postpartum, I was diagnosed with a grade 2 cystocele, a grade 2 rectocele, and a grade 1 uterine prolapse. I now only have a grade 1 cystocele. So I know that, this is well known that, rectoceles are a lot harder to heal than cystoceles are. But the reason I think mine improved was because my posterior wall was being pulled forward by my perineal tear. Once I addressed the scar tissue, that tissue was able to go back upwards, and so this isn't the case for everyone, but it can be the case for some people. So yes, I have had a grade improvement. This is a hard one. I love so many different parts about my job, but I would say the thing that makes me excited the most, or just love what I do the most, is when things click for my patients, whether it be pelvic patients or an ortho patient or whoever, a chronic pain patient, I don't care. When they start putting 2 and 2 together with what they're learning from me and what their body is telling them, and the habit changes that they're making, and all of a sudden they're like, oh, I get why this is happening now. And it's like all of a sudden there's so much more buy-in for them to improve their own situation, and they exponentially start to improve once they realize how much personal responsibility has to be involved in their healing and how much power they actually have. The breathing stuff can be hard to get. I want to just start by saying that you don't have to do it perfectly. I think people really get set on I have to do this 360 breathing thing absolutely perfectly, or I'm ruining my pelvic floor, whatever. That's not the case at all. Changing your breathing pattern takes a long time. It takes a long time. It's like changing your posture. It takes time. If you feel like you're really fighting your body to get good rib expansion, you're probably dealing with muscle tension or joint stiffness that's limiting your ability to do it well. So if you have those things and you're not addressing those first, you're going to continue fighting your body in order to breathe well. So make sure that if you're seeing a PT or whatever program you're working through addresses your ability to move your rib cage well. Once those things are addressed, then 360 breathing should be a lot easier. My favorite cue to help people feel what a relaxed pelvic floor feels like is to talk about the elevator of the pelvic floor. So at rest, you could think about being at the ground level, and you can contract up to level 1, you can contract up to level 2, and then you can release down to the ground level. And with an inhale, you can drop the elevator to the basement. So if you are having a hard time getting to the basement, I guess, do a little contraction and then take a big inhale down into your pelvic floor, not bearing down, but you should feel that drop down into the basement, and that's what fully relaxed feels like. With scar tissue mobilizing. So I would use my finger or my pelvic wand internally on my scar, rub back and forth along the base of it, release the superficial muscles, and then also pinch the perineum and go back and forth like this, and then massage the scar a little bit like this also, and that seemed to resolve that issue for me. Your PT can help you, or if you need more help, I do have a reel on scar tissue mobilizing. I believe I have it in my hypertonic pelvic floor highlight. Okay, so the walnut. If you're not sure what the walnut is, stop here. Go look at my walnut highlight. It's about the urethra looking more prominent after having a vaginal delivery, and the urethral rugae, the tissue that looks like ground beef, is more obvious after having a vaginal delivery. This tissue is not necessarily a prolapse. It can be, but it's not necessarily one. It can be very bothersome because we have so many nerve endings right there. Excuse me, that the presence of it in the vaginal canal can be really bothersome. So my biggest tips for this particular tissue: hypopressives, huge relief for this guy in particular. Second is learning to engage and strengthen the front of the pelvic floor and using TA to do that. So if you feel like you have a lot of weakness engaging the front versus the back. Okay, so yes, if you have difficulty engaging the front of the pelvic floor compared to the back of the pelvic floor, I encourage you to do your pelvic floor strengthening stuff in an anterior tilt. So if you're sitting, instead of sitting rounded and contract, you can try that. So try rounding, contract your pelvic floor. You're going to feel it more in the back. If you come into an anterior pelvic tilt, so tilting forward, lengthening the tissues in the front, now do a pelvic floor contraction. You should feel it more in the front. I do not have an avulsion. So for those of you who don't know what an avulsion is, it's when one of the pelvic floor muscles, often the puborectalis or pubococcygeus, tears away from the bone. So these two muscles, if this is the urethra here, they attach on the sides of it, on the pubic bone. And all of it on both sides or partial on one side or the other can tear away. This increases someone's risk of developing prolapse because the muscular and fascial support of the organs from underneath is compromised. I do have a few thoughts on this. So if you missed my interview with Dr. Fitzgerald, this is in my surgery highlight. It's the second interview we did all about surgery. She made the point that if you're younger and having a prolapse repair, using your native tissues is probably best, because if later down the line you need to have a second repair done, you can do mesh the second time. It's harder to have a second repair if you've had mesh the first time. One thing to consider, though, is if you are hypermobile, if you have a diagnosis of EDS, Ehlers-Danlos syndrome, or another connective tissue disorder, using your own native tissues might not be as successful of an outcome because you already have this underlying collagen synthesis disorder, right? So in that case, starting with mesh might be better. This is definitely going to be a conversation between you and your doctor, but those are just a few things that we talked about in that interview. It's frustrating, huh? So I think it's because, number one, there is a push to not actually diagnose grade 1 prolapses as true prolapses because so many people have them, that it's considered an anatomical norm or variation of normal. However, I have an issue with this because I feel like a lot of grade 1s are still symptomatic, and if you have a grade 1, you should be told about it because you want to make sure it doesn't progress to a grade 2, right, or more. And that would be something that you're not going to do in your day-to-day life right now, but if you end up having a chronic coughing or chronic constipation or your lifting mechanics are really decades, then it could potentially progress. I'm not saying if you have a grade 1 fear that it's going to all of a sudden become something worse, but I think that's one of the reasons. The second is different grading systems, so the PopQ versus the Baden-Walker. So different providers are using different systems to grade. It also depends on your body and how it's presenting at that time. So if you had an appointment early in the morning versus at the end of a long day, your prolapse is going to look different. If you were more active one day than another, your prolapse is going to look different. If you were in a different part of your cycle, your prolapse is going to look a little bit different. So even for me, I'll give someone a diagnosis. I don't actually diagnose. Blah, blah, blah. I've got my own thoughts on that. And the next time I see them, it'll look different. And I'm okay telling them, hey, it looks a little bit different than last time. This might be why. Not a big deal. We're treating it all the same, right? So also don't get caught up on your grade and what exactly you're dealing with, because sometimes it doesn't matter. A lot of times it doesn't matter. A lot of the time we're still going to be treating it relatively the same way, and that's what matters.